Good morning, and thank you for the opportunity. I have a lot of interesting things to talk about because there's been some amazing developments just within the past few years. This could be MCAS, this could be EDS, this can be Chiari, because of the years it takes to diagnose individuals that have this triad of issues between the connective tissue and the embedded mast cells and the somatosensory network. These are my disclosures and doesn't have anything to pertain or really no conflict of interest. And this is going to be the agenda. So I'm an allergy immunology specialist, and I had to learn about connective tissue issues. We're going to talk about mast cell disease, how it contributes to the fragility of tissue, and then some of the neurosurgery concerns that are associated with having EDS and the comorbidities of neuroimmune dysregulation. And there's about 70 slides, I'm warning you. A lot to talk about, but really the summary is if you suspect spinal cord or central nervous system issues with this type of symptomatology, you really need to think about screening for connective tissue issues as well as mast cell dysfunction. So my journey started, I always wanted to be a physician. My father, my junior year of college, I don't want you to go into medicine because it's becoming such a business and physicians are not having any more help. So I deviated and actually became a research technician at Rockefeller just as the HIV and the allergy epidemics were starting up in New York City. And that led to a 13-year odyssey. So I actually went around my dad and ended up getting an MD PhD at University of Pennsylvania, and then made my way up to Boston and then down to New York. So up and down I-95 in order to get training to be an immunology specialist. And interestingly enough, despite that, the only thing I learned about mast cells was in the context of allergies. So here, this is a cell, and the only way I learned about it was in the context of disease. And so when people would present with symptoms involving the skin, the GI tract, the central nervous system, the urinary genital tract, I would only do allergy testing. And this was my life, seeing 20, 25 patients a day, skin test, get the story, repeat. And really just focusing on this one single receptor. But that's kind of silly because this is a cell that's in every single part of your body, is in organisms as low as, not low, but sea squirts, and have multiple functions besides just causing you to eat peanuts and potentially have a bad outcome. And who really helped me illustrate this was this little boy that I had seen. He was 4 years old. He literally had seen 30 physicians because he had, these hypersensitivity reactions were involving every single part of his organ system. So you can imagine the siloed healthcare system that we had. You're going to be going to every different specialist to kind of figure out why this is happening. So he kept on going to different specialists, and they all said allergy, except for the allergists, 10 of them. So you can imagine how frustrating this is. But when he came to see me, and I wasn't going to repeat the same testing that the previous 10 allergists had done, I was aware of this report that was back in 1982 showing that individuals actually had physical triggers that can actually cause mast cell changes that can in fact impact any connective tissue where these physical triggers had caused an exposure. And I think what happened within the past 6 years, there was two gentlemen who just won the Nobel Prize talking about somatosensory nerves. And these somatosensory nerves actually have receptors that can detect dust mites, bacteria, and then they educate the mast cells that there's a problem, and then the mast cells use their receptors to figure out what kind of problem, and then will release chemicals. So this is the dynamic that's happening. This is the triad of somatosensory nerves and mast cells doing surveillance, repair, and also response. And so what we've been finding what I've been seeing over the past 10 years, and I think all of us who've been practicing as well, we're seeing this link between hypermobility, and hypermobility will run with proprioceptive defects. So here you're having, again, issues with the autonomic nervous system if you have evidence of connective tissue issues. And if that's the case, you're going to start tickling the mast cells as well. So I had to try to understand what is the link between hypermobility and hypersensitivity? And could it be through the mast cell compartment? So I had to kind of unlearn all that I was taught those 13 years going up and down I-95. and try to understand these cells that are embedded in connective tissue. These are not blood cells. These are in the tissue doing their job, have the ability to cause this disorganization in the connective tissue. Because guess what? They elicit a lot of chemicals, including enzymes that can modify the connective tissue. So this is a gentleman at Stanford, Stephen Galley, who's been doing research on mast cells for close to 25 years. And he gave this history about the fact that these were originally identified in the 1800s and never got a job until 1989 when they found the link between IgE and mast cells. But his comment was, do you really think we have mast cells and IgE in order to eat peanuts and die? And that's not the case. So these cells are found in lots of different organisms. They sit in every single part of your body. They have a very close relationship with the borders as well as the vasculature and the nerves, because their job is to figure out, is there a problem? And if it is a problem, what kind? And then what do I have in my toolbox to control it? And again, very close relationship between the somatosensory nerves and the mast cells. And this is a paper that was done between a joint effort, and this is why it's really important to have a collaborative effort. This was a joint effort between Allergy, Immunology, and Neurology at Brigham and Women's. And they showed if you have evidence of an autonomic neuropathy and you have evidence of mast cell disease, if you have a mast cell activation event, you can drop your blood pressure by 30% to your head, which is going to be an issue if you're doing surgery and you have too cold an operating room, you're using chemicals that have the ability to be directly recognized by either the nerves or the mast cells. And then depending on what the mast cells see, they have the ability to release chemicals that can directly injure cells. They have the ability to recruit and help, including eosinophils, lymphocytes, monocytes, macrophages. They can alter blood flow because they release heparin as well as platelet activating factor. I can tell you I've had 2 patients who've had anaphylaxis and disseminated intravaginal coagulation, meaning they started to bleed and clot at the same time from the allergic reaction. And they also participate in reproduction. So there's a huge issue with women when they have a connective tissue issue and mast cell disease. When they go in and out of their cycle, their symptoms can get worse. And so what happens when you have a cell that has the ability to impact so many different functions in your body, and they do it under benign circumstances? You go from a cold room to a hot room. You have a certain food that has a chemical in it that the mast cells recognize, not necessarily by the antibody. And so this is a paper that was in the New England Journal of Medicine showing that if you have inappropriate release of these chemicals, you can impact any organ system. And this can happen through lots of different receptors besides the allergy or IgE Fc epsilon receptor. And so what was happening in that little boy, he was actually having spontaneous release of these chemicals from mast cells, basically going through what's called chronic inducible mast cell degranulation. So it is these physical triggers that are causing him to release these chemicals inappropriately. And it could be from chemicals from food, it could be clothing, it could be change in temperature, it could be internal changes of hormones that will cause these mast cells to release these chemicals and impact any organ system depending on that time. God bless you. So I want you to stay away from the term allergies. I want you to think about, is this a mast cell activation issue or not? And this was actually coined in 2011. And literally, you can see, depending on where these mast cells are releasing these chemicals, you can have organ system issues anywhere. So I've been seeing patients for the past decade, and they come in saying, I got mast cell. I'm like, take a swig of water and then try to think about how I can help. But you can see all the different systems that can have an involvement. And then here's, if you have a connective tissue issue that's going like this all the time, you can cause mast cell degranulation, and the mast cell degranulation and secretion can also complicate the autonomic neuropathy issues as well. So how do you diagnose mast cell activation syndrome? Well, do you have at least 2 organ systems involved? Brain and skin, gut and urinary tract, mood disorders, along with joint pain. Then do you get better with medicines that target the mast cells? Histamine blockers, leukotriene blockers. There's some more fancy biologics as well. And then after you get a good story, what data do you have to support that the mast cells are misbehaving? And then once you decide that mast cells are misbehaving, you need to figure out why they're misbehaving. You just don't want to take medicines to suppress the mast cells because they're actually trying to help out in 90% of the cases that I have seen. And basically it breaks down to, do you have a defect within the mast cells? That's rare. Maybe 35,000 cases in the US, but there is one population I'll talk about a little bit more, and those are the ones that have what's called hyperalpha-tryptophanemia. And interestingly enough, that's 7% of the Caucasian population. But for the most part, mast cells are releasing these chemicals or breaking bad because they're being exposed to an environment that's triggering them. This is a very toxic environment, and you have to admit, for us more seasoned individuals in the room, the environment that we grew up in was very different than what our children are growing up in. What we eat, what we wear, the air we breathe, the fact that we spend 95% of our time inside of something that's been manufactured, all of those are chemicals and climate issues that are causing our nervous system and our immune system to be on a higher alert, chronically. So the type of testing that I now do when I see somebody having hypersensitivity issues, which might be going through the nervous system that drags in the mast cells, or it's going through the mast cells, which drags in the nervous system, which then can cause chronic changes in the connective tissue, especially in parts of the body that may be a little bit more at risk for having compromise, such as the atlas, the lumbosacral spine, certain aspects of the spinal cord as well. So this is rare. This little boy has systemic mastocytosis. And interestingly enough, he also complained about joint pain. So, and the problem with our siloed healthcare system, we have a tendency to focus on the symptoms the patient present. So why would an allergy immunology specialist bend a child to see whether or not they're hypermobile or not? Well, we need to do that because hypermobility tracks with anxiety in children. Hypermobility tracks with neurogastrointestinal distress. So it's important to try to figure out whether the mast cells are misbehaving and actually causing something about hypermobility issues and connective tissue compromise. But for the majority of the patients, the mast cells are just trying to help out, but they're confused. And so we have lots of different receptors besides the allergy receptor. So this is the allergy receptor, but here, this is the issue for a lot of anesthetic agents and as well as fluoroquinolones. This will cause direct degranulation of the mast cells. You also, when you're trying to give pain medication, there are opioid receptors. So if you're trying to give like Dilaudid or morphine, you're actually causing the mast cells to degranulate and bring in more inflammation, so you're going to diminish the anesthetic effects. You have complement, and this is the biggest one I would have to say. The research that's out of Chip Norris's lab has identified that a strong link between complement dysregulation and hypermobile Ehlers Danlos Syndrome, and I'll get into more details about that as well. So this is an observation that came out of NIH in 2016. They found that if you had an elevated serum tryptase level, you're at increased risk of having 2, 3, or 4 times the copy number of a normal gene. So you're not going to pick this up in whole genome sequences. You have to look for it. So it's really important to understand that when you ask a question genetically, you have to understand, is this a normal gene, but too many or too little copies? Or is there actual, variation in what might be controlling the gene expression? So this is 7% of the Caucasian population, and these individuals are at increased risk for having hypermobility, mast cell activation disease, and connective tissue issues. And then another link between mast cells and nerves were these individuals that have vibration-induced urticaria, but they're also at risk for vibration-induced anaphylaxis. And I want to emphasize that if you're in a cold operating room, it might not necessarily be vibration. It could also be temperature that can cause the mast cells to degranulate. So it's really important when you have somebody that you suspect have a connective tissue issue or mast cell disease, there has to be temperature control in the room as well. And then this is a paper that I had done with 2 other colleagues where we just did a retrospective analysis on individuals who suspect that they had mast cell activation disease. And they went through the whole battery of testing, including the fact whether or not they had evidence of hypermobility. And 1 out of 5 individuals had evidence. And they were just complaining of hypersensitivity issues, congestion issues, GI distress, neuropsychiatric issues, joint pain. 1 out of 5 had evidence of mast cell activation disease, hypermobility, and low antibody levels, which means they're immunocompromised. So now exposures to certain bacteria and viruses like COVID, will cause them to have a worsening of their neuroimmune issues. And more data to suggest that there's a link between mast cell activation, autonomic neuropathy, and individuals that have connective tissue disease has come from other sources as well. So this was out of Canada, where they showed this is as a new cluster back in 2011. Cincinnati had identified that individuals that had evidence of connective tissue disease were 3 times as likely to develop eosinophilic disorders. And then this was a paper that I had done with my colleagues where we just looked at hypermobility and hypersensitivity, and they all had hypersensitivity issues, but they had a normal tryptase, and their IgE level was less than 10. So looking for allergies, you're going to completely miss the diagnosis. And the top one actually is a gentleman, Dave Lee. We were residents together in Boston. He actually had a science paper, I was a little jealous about that, where he showed that there was a strong correlation between dysregulation of the mast cell compartment and joint issues as well. And they have a tendency to be hypermobile. So again, this hypersensitivity and hypermobility seems to be tracking together. And we need to think about that when individuals present with symptoms that suggest autonomic neuropathy or neuropsychiatric issues. So hypermobility is tracking with hypersensitivity. And so now the question is, why might that be the case? And so we wanted to do an analysis at Medical University of South Carolina to see whether or not we can identify issues that may be contributing to mast cell dysregulation. And the biggest factor has been complement. And if we don't know about mast cells, we know even less about the complement system. So let's talk about Ehlers Danlos syndrome. It's supposedly rare, but if you look at all the other variants besides hypermobile Ehlers Danlos syndrome, it's estimated that people with the hypermobile phenotype, it's anywhere from, if you talk to Dr. Sunil Patel, he'll say 1 to 250. I'll say 1 to 500 based on the patients that we see. But we need large-scale studies to understand how many individuals have evidence of hypermobility, and then they should be screened for autonomic neuropathy issues and structural issues involving the brain and the spinal cord. Just to give you an idea of the individuals that have had hypermobility issues and then end up having their career and lives derailed, the more recent study was this gentleman who was a hockey player who had to retire at 22 because he had exaggerated injuries, and they found out that he had EDS. This is Miss America, who also had spinal cord issues and in the setting of hEDS as well. And this is a patient that I know are now being referred to commonly from our emergency department again, just having all these issues. She's affected, and all 3 of her children are affected as well. So the thing about connective tissue issues, it is the brick and mortar of every part of your body. So you can have problems in any part of your body, and that's what's important to understand. But again, we have a very siloed healthcare system, and primary care, this is kind of beyond their working knowledge, and specialists have a tendency to stick in their corner of the sandbox, but we need to kind of peek over that sandbox and look outside of our comfort zone to understand that the favorite phrase is, if you can't connect the issue, think connective tissue. So these are some of the common manifestations in individuals that have hypermobility syndrome. So Chiari malformation, spinal cord disorders, tardive cysts, segmental kyphosis instability, and headache disorders. And unfortunately, when it comes to identifying these individuals that have these neurological issues in the setting of EDS, the time to diagnosis after initial onset of symptoms can be up to 20 years. It's a lot of wear and tear that actually just causes more injury. And a lot of that's simply because, again, solid healthcare system and poor education of practitioners. And you know there's no public announcements on looking for EDS, Chiari malformation, or mast cell disease. So the genetics was only updated in 2017. And unfortunately, the most common one does not have we know it's autosomal dominant, but the gene's never been identified until recently. And some of the information, one clue for that would be the fact that out of all the other phenotypes, one other does not have a gene variant that impacts either the extracellular matrix or the collagen matrix itself, and that's periodontal EDS. That is a gain of function in the complement system, which was identified in 2016. So here you have a much more rare phenotype that might give us information about the hypermobile type. And what happens when you have ongoing connective tissue integrity issues? So you can have ligament laxity, increased tissue fragility, extracellular matrix alterations, and also, again, increased susceptibility to biophysical deformative stressings. So, as I was saying before, periodontal EDS is actually a gain of function in the complement system. And this is the data, this is the paper that came out in 2016. And what was interesting, that these people, they have more complement, which means they have an increased ability to detect chemicals, infectious agents, cells that are dying. So these individuals increase risk for developing not only certain types of infections, but also hypermobility disorders and autoimmune disorders as well. And they're also at risk for having generalized hypermobility. So this is the work that's coming out of the Norris lab, has shown that he has, I believe, over 1,000, he has a patient cohort of 15,000. Some of them are physician diagnosed and some of them are self-diagnosed. But the ones that were physician diagnosed, he found that they actually had a mutation in the kallikrein system. Kallikrein system talks to the complement system all the time. And all these individuals had evidence of symptoms and signs that are consistent with the diagnosis of hypermobility syndrome, a spectrum disorder, as well as hypermobile Ehlers Danlos syndrome. Complement plays a key role. This is one of the original mast cell degranulators. It's actually called aflatoxins. And what happens is, not only do you have a release of like histamine and leukotrienes, you have a release of proteins that have the ability to modify the connective tissue, and you have the ability to release chemicals that modify the blood flow as well. So these individuals have chronic leakage into the interstitium, which might actually cause secondary mitochondrial dysfunction as well. So, not tightly regulated mast cell compartments can lead to mast cell activation syndromes, hypermobility issues, and the two of those are going to cause structural and inflammatory issues with the brain and the spinal cord. So, the road to abnormal connective tissue homeostasis, you have the much more rare defect, and I use this analysis of that plane, that the door, it was not, they used bad building materials and the door flew off. That's rare. What is common is this poor tragedy that happened in Miami where they didn't keep up the maintenance on the building and it collapsed. This is what's happening with a lot of the patients that have evidence of hypermobility. And as long as this neuroinflammation keeps on going on, you're going to compromise, what I would say watershed areas of the spinal cord and brain that leads to deformities in the spinal cord and brain as well. So you have the hypermobility issues, you have the hypersensitivity issues. What are the implications when you're thinking about performing neurosurgery on patients like this? So you have to take in consideration the fragility of the connective tissue when you cut, and then when you try to put it back together again. As you can tell, I'm not a surgeon, sorry. You have mechanical overload. So it's really important to address that. So once you do the surgery, you really need to partner with PT, OT, speech to make sure that that conditioning helps with better realignment as the tissues are healing as well. And then you also have to take care of this immunological cascade that can happen from both physical and chemical exposures. So this was an article that quite a few people in this room contributed to back in 2017. It's going to be updated in 2026. But the focus really should be, let's think about hypersensitivity issues in these individuals. The way to diagnose mast cell activation disease is, again, do you have signs and symptoms in at least two organ systems? And what I have found, if you don't ask the patients, they're not going to tell you. So I'm going to show you a questionnaire that I use in order to kind of better identify individuals that may be having hypersensitivity issues. You also have to do the screen for hypermobility. But if you're not comfortable about doing the hypermobility schedule, actually, the Paris EDS centers have been working for the past 15 years, and they actually developed a 9-question questionnaire. And if you answer 5 positive to one of the 9 questions, you have a 98% sensitivity and specificity of having an EDS variant. So just with questionnaires alone, you might be able to identify the hypermobility and the hypersensitivity. Again, it's important to understand that most of the individuals that have mast cell dysfunction, it's outside factors that are driving the mast cells to inappropriately release those chemicals. And this is work done by Dr. Klinger, who reported on the fact that individuals that underwent tethered cord surgery were at increased risk for having complications from the surgery. If not done a certain way, they're much more likely to have severe symptoms after the surgery as well. So the question is, what can you do to try to improve the risk of complications that are associated in operating in individuals that have Chiari malformation, Tarlov cysts, or spinal cord instabilities? Well, first you need to recognize the fact that, again, they don't heal normally. So they're going to need more time to heal, which means those sutures need to be in longer and they need to be placed in a certain way. And I'll leave that up to Dr. Klinger to elaborate on that. You also need to appreciate that those nerves that are embedded in the cord are going to be problematic, contributing to autonomic neuropathy issues. And those autonomic neuropathy issues can be aggravated by things that trigger the mast cells. Again, certain anesthetic agents, certain antibiotics, also physical triggers that are in the rooms that they undergo the operation and are recovering as well. This is the screening questionnaire for
Can you hear me?
Whether or not you want to identify an individual with EDS. So this these 9 questions, and if you answer 5, this person should undergo full screening for an Ehlers Danlos variant. This is the questionnaire for mast cell activation syndrome. It's not something you can just hand it to the patient, or the patient can review it. And then if they're positive, then you refer them out for further evaluation on why those mast cells are misbehaving. And then just to give you an idea of the chemicals that need to be avoided in these individuals, because of this MERG receptor, they can't get fluoroquinolones, they can't get vancomycin. I actually had a patient I had to evaluate at Mount Sinai when I was there, and they underwent AAI repair, and they gave her vancomycin because they detected staph, and she ended up with DRESS syndrome. So it's really important. If you can avoid certain antibiotics, you can minimize them having complications from the procedure as well. The complement can be activated by infections, by certain chemicals as well. So it's important to know that there's certain medications that are better tolerated in this column, and these are the ones that need to be avoided unless you have no choice. And if you have to use these medications, you should have consultation from an allergy immunology specialist in order to onboard it. And also just want to let you know that individuals that have issues like Chiari malformation or AAI or CCI, they're at risk for having a functional vagotomy. If you compromise the vagus, you'll end up with more inflammation. So there's another reason why it's important to understand the relationship between the nervous system and the mast cell compartment, because now you're going to have increased intolerance to harmless substances, including foods and medications. So these are some of the preoperative recommendations. I'm just going to focus more on the fact that if you have somebody who has autonomic neuropathy, you need to hydrate them well and try to reduce their susceptibility to having that blood pressure drop, because then they're going to have non-epileptic seizures. I've seen that a few times. They'll drop their blood pressure post-operatively. And I actually had a PA that was taking care of one patient, said that this was psychogenic. I'm like, no, you lift her head up, blood pressure drops, she's going to go into a seizure. So to kind of round up, and this is a wonderful article by Pradeep Chopra and Linda Bluestein, who have been involved with EDS and neuropathic issues for many, many years. It's a free download, but I'm just going to highlight some of the things that they talked about. Again, it's really important to screen these patients. If you have someone who has suspected Chiari, AAI, CCI, or occult tethered cord, It's really important to do a thorough questionnaire to evaluate the possibility of EDS as well as mast cell dysfunction. And once you get that diagnosis, those diagnoses, you'll know that there's certain conditions to be optimized and also avoidance of certain medications that can make things worse for these patients. Local anesthetics don't work very well in these patients because you inject and it just spreads out. So you have to probably inundate even more in order to get that local effect. Pain management, actually ketamine does not cause mast cells to degranulate. So this is a great way to provide pain relief without necessarily taking away causing a hypersensitivity reaction. And so the summary is, you have individuals that have connective tissue issues that are increased risk for these type of neurosurgical issues. EDS is a very complex disease involving both autonomic nervous system and mast cell dysregulation. And unfortunately, I put this map up here to show you that we're scattered all over the country, except for at Medical University, South Carolina. And we should be opening our doors sometime in the middle of September. But there we have neurosurgery, anesthesia, everyone's being educated on these diseases that I just discussed. And we meet once a month in order to make sure that workflow and all the precautions that we talked about are in place for the patients. And also we try to learn from our mistakes, because that's going to happen. So if we don't have that collaborative effort, we're not going to change the course and trajectory of people who are dealing with these issues. Again, there's fragility, mechanical overload, and immune dysregulation. And I have to tell you, we have a lot of research to do, not only regarding clinical care, but education. How can we better inform all our colleagues in these institutions? And I have to tell you, MUSC has been the only one, and I've tried this at least 4 different places now. They're the only ones that are willing to invest in understanding the complexity of these patients and helping the families deal with this triage of debilitating disorders that can only come under control if you address each leg. And I just want to thank you for your attention.